Welcome, everyone, to the Transformation Nurse Academy podcast. This is our weekly episode, Talk with Kevin, where we cover topics for all nursing fields with extra emphasis on emergency and critical nursing. Get ready for candid discussions that explore the vast landscape of nursing and beyond.
All right, welcome, bitches, to the Transformation Nurse Academy podcast. This is Kevin. I'm your host, and I hope you have been listening and tuning in. So please follow us on Apple Podcasts, Spotify, Amazon Music, YouTube, Podbeam, all them motherfucking shit. Visit our website at Transformation Nurse Academy podcast. Today we're going to be doing our cardiovascular assessment. So we started out with the adult triage. We started out with the pediatric triage. And then last week we did the neurological assessment. So this week we're going to be talking about the cardiovascular system, and we're going to understanding the heart and its functions and what you need to do as a nurse to make sure that you're assessing your cardiac system so you don't miss shit on your fucking patient. So introduction to the cardiovascular system. The cardiovascular system, also known as the circulatory system, is responsible for transporting blood, nutrients, oxygen, carbon dioxide, hormones throughout the body. So when we talk about nutrients, we're talking about electrolytes. We're talking about sodium, potassium, magnesium, calcium. We're talking about glucose. So don't just get stuck on fucking oxygen, because the oxygen can come back to bite you in the ass if you're not paying attention to the other shit. So key components, like I said, include the heart. It includes your blood vessels. It includes nerves and in the blood. All right. So the anatomy of the heart. The heart is a muscular organ located in the chest cavity. It consists of 4 chambers, 2 atria, and 2 ventricles. The heart has 4 valves. It has the mitral valve, the tricuspid valve, the aortic valve, and the pulmonary valves. And I'm not sure if you can see this right here, but on the screen on your left is the right atrium, and then you have the right ventricle. So in between the right atrium and the right ventricle is the tricuspid valve. From the right ventricle, you're going to go up to the pulmonary valve, up to the semilunar pulmonary valve. And then you're going to go up here to the pulmonary artery, and then it goes to the lungs. So typically in the body, the arteries carry oxygen away from the heart and carry oxygenated blood, and the veins carry back the deoxygenated blood. However, in the heart, the pulmonary artery is the only artery that carries deoxygenated blood. And then it goes to the lungs, picks up oxygen, comes back via the pulmonary vein. And the pulmonary vein is the only vein that carries oxygenated blood. And then it goes into the left atrium. Then it goes into the left ventricle, up through the aortic valve, out up to the carotid arteries, and then goes out to the descending aorta, out to the body. The right atrium, again, receives deoxygenated blood from the body via the superior and the inferior vena cava. So the superior vena cava is up here. The inferior venous cava is down here. So the right atrium receives deoxygenated blood from the body via the superior and inferior vena cava and the coronary sinus. The blood then flows to the tricuspid valves into the right ventricle, which pumps blood into the pulmonary arteries and to the lungs for oxygenation. And then, like we said, on the left side, it comes back via the left atrium after it has received the oxygenation from the lungs, and it goes into the pulmonary veins. The blood flows through the mitral valve into the left ventricle, and then the left ventricle pumps oxygenated blood to the aorta, which distributes it through the rest of the body. All right, so blood flow. We talked about this. Oxygen-poor blood enters the right atrium. Then it goes, like we said, I'm not going to repeat this. But let's talk about the cardiac cycle. So the cardiac cycle, they got 3 phases here. The cardiac cycle includes atrial systole, ventricular systole, and then diastole. And each are crucial for maintaining your circulation. So atrial systole, so during this phase, the atrial contract, pumping blood into the ventricles. So you got the 2 chambers on the top, you got 2 chambers on the bottom. 2 chambers on the top of the atria, the 2 chambers on the bottom of the ventricles. This occurs just after the P wave. So this occurs when the atrials contract, you get a P wave, and then the atria relax, you don't really get anything because the ventricles are beating so fast, so you get this little flat line. So between the P wave and the R wave, we call that the PR interval, and the normal PR interval is 0.20 or less. The atrial contraction ensures that the ventricles are filled with blood before they contract. This phase contributes to about 20 to 30% of the ventricular filling. Now, I didn't put this in here But there's also something that's called the atrial kick. So you get about 20 to 30% of your blood into the ventricles from the atrial contraction, but you get the rest of it from the atrial kicks, like a little So if you lose your atrial kick, then you're going to lose a lot of volume. All right. So ventricle systole, following the atrial systole, the ventricles contract. This phase is divided into two parts: isovolumetric contraction and then ventricular ejection. So during the isovolumetric contraction, all the heart valves are closed, and then the pressure within the ventricles increase without a change in volume. When the ventricular pressure exceeds the pressure in the aorta and the pulmonary artery, so we can monitor the SVR, we can monitor the pulmonary wedge pressure. These are the things that we're looking for to see if your left ventricle is working okay, or if you have some kind of issue, aortic stenosis. When the ventricular pressure exceeds the pressure of the aorta and the pulmonary artery, the aortic valve and the pulmonary veins open, allowing blood to be injected from the heart. This phase corresponds with the QRS on the EKG. So the atria, the P wave is the atria contracting. The QRS complex is the ventricles contracting, and then when they relax, they call it the T wave. So that's the diastole, and is the phase where the heart muscles relax. So during this phase, the ventricles fill with blood passively as the atrioventricular valves, talking about the tricuspid, tri is on the right, mi is on the left, open, and then diastole includes both isovolumetric relaxation, where the ventricles relax and all the valves are closed, and then ventricular filling, where the atrioventricular valves are open. That's that lub dub here, lub dub, lub dub. Those are called S1, S2 cardiac sounds. If you hear lub dub dub or lub dub dub dub, that's S. If you hear three sounds, that's a S3. If you hear four sounds, that's a S4. Could be some type of cardiac stenosis like aortic stenosis, some kind of valve stenosis. It could be regurgitation. There's a lot of different reasons for that. And that's why you want to notice these sounds so you can let the physician know. And maybe we need to order more tests: EKG, cardiac labs, cardiac echocardiogram, x ray to look at further investigating what's causing those abnormal sounds. So again, this phase, this relaxation phase, is the phase that's represented by the T wave, and then the subsequent period until the P wave on the EKG. So you see P, QRST, and then you keep going back over again. So diastole is critical as it allows the heart chambers to fill with blood. So if your heart chambers aren't relaxed, you can't feel enough volume and your cardiac output is going to drop. All right. So the cardiac system, the electrical conduction system, is known as the SA node and the AV node. You got the bundle of His, you got the left and right branches, left and right bundle branches, and then you have the Purkinje fiber. So over here on the right hand side of the screen, you can see in the right atrium, right at kind of at the bottom right hand corner of it, you can see that there's the SA node is right around the superior vena cava, and the AV node is down here right at the bottom between the AV and the ventricles. That's why it's called the AV, atrioventricular node. The sinus node is your pacemaker. It's what makes your heart beat. So if the heart is working correctly and the SA node is working correctly, you should have a normal heart rate between 60 and 100. If the SA node is failing or if the SA node fails, the AV node picks up and then you'd have a heart rate around 40 to 60. If the AV node fails and the SA node fails, the bundle of His right here at the top of your septum wall, at the top of the septum, this is called the bundle of His. If it has to pick up the work, then the heart rate's going to be around 20 to 30, 20 to 40. And if it fails, then you're going to be, the Purkinje fibers are going to try to pick up the slack, and then the heart rate drops down like into the 10 into the 20s. So the SA node, again, is located in the right atrium. It acts as the heart's natural pacemaker. It generates impulses that causes the atria to contract. These impulses travel to the atrioventricular node or the AV node, where there is a slight delay to allow the ventricles to fill. The impulses then move down the bundle of His, which then divide into the right and left bundle branches. And then finally, they go down to the Purkinje fibers, causing the whole ventricles to contract. And then the whole system starts all over again. So if you have somebody comes into the ED or into your med-surg tele floor, and the heart rate's less than 40, heart rate's less than 50, and they're symptomatic, maybe it could be that their SA node is malfiring, or maybe their SA node is failing. It could be somewhere in a cardiac cell somewhere that's causing it. If you look over here on the right-hand side from the SA node, you have all these little white lines. If you could see on here in the picture, these little white lines, they're called internodal pathways. So if you look right here on the left, you have the anterior internodal pathway, you have the middle internodal pathway, and the posterior nodal pathway. And over here, you got the Bachman's bundle. When you talk about a Winky Bach, that is the Winky Bach bundle that gets messed up. And these are also like little pathways that sends out the signal to make your atria contract to force the signal down the track there. So when you're doing a cardiovascular assessment, though, as a nurse, the cardiovascular assessment in the emergency department or the med surg settings, you want to make sure that you take a good history. History is vital. So when taking a history, you want to ask the patient about the chest pain. What kind of chest pain is it? Where is it? How long has it been here? Does it radiate? Does it get worse with breathing? Does it get worse with movement? Are you having shortness of breath? Are you having palpitations? Are you dizzy? Look at their feet. Look at their cat refills. Do they have club fingers? They got cat refills 2 to 3 seconds or less, or is it delayed? Do they have pitting edema? If they do have pitting edema, is it +1? Is it +2? Is it +3? These are things are important. Because if people have peripheral edema, is it caused by cardiac issues like their heart is failing, congestive heart failure, or some type of hypertrophy? Do they have a family history of cardiovascular disease? So understanding these characteristics of chest pains, you want to know the onset, the duration, the triggers. This can help you differentiate between angina and cardiac issues like MI or something else. So you want to inquire about the shortness of breath. When you inquire about the shortness of breath, does it only happen at nighttime? Is it when they're lying down? Is it when they're sitting up? Is it when they're walking? During your physical exam, you want to look for skin color. Are they pale? Are they cyanotic? Do they have indications of poor perfusion? Are they mottled? Or what are the O2 sats on the monitor? What is their CO2? Again, you want to assess for edema, pitting versus non-pitting. You want to check for jugular vein distension to see if there's got backflow into the jugular veins, which is a sign of fluid overload, right? So right here, we talk about jugular vein distension, which can signal elevated central venous pressure or CVP. You want to palpate their peripheral pulses, note their strength, note their symmetry. Are they equal on both sides? Do you feel the lub dub or do you feel extra beats? When we talk about checking the pulse, and sometimes at school they still tell you to check the pulse for 15 seconds and multiply by 4, but that's not a good idea because what if you have somebody that has a irregular heart rate and you might miss it if you count that way. So, do you have any thrills? Is there any kind of vibrations or any thrills? If you listen up here with your stethoscope on the top right hand corner, sometimes if you have aortic stenosis or things like that, you can hear the whoo, whoo, whoo. That's a sign of aortic stenosis. If their heart is hypertrophic, meaning that it's kind of enlarged, this blood flow can be turbulent and make these different sounds. So don't just listen for the normal S1, S2. Listen for the rubs, listen for the gallops. So gallops are called S3s and S4s and can be signs of heart failure or some type of ventricular dysfunction. So you want to make sure that when you're assessing that you assess properly. Common vascular disease, common cardiovascular diseases could be coronary artery disease. So coronary artery disease is caused by plaque buildup in the coronary arteries, leading to chest pain, shortness of breath. Treatments include antiplatelets, statins, and then maybe they may have to go for an angiogram to remove all that plaque. If they do have coronary artery disease, it can clog up here in the carotid arteries and they can have a piece of that plaque break off and cause a stroke. Your patient may need to go have an endarterectomy, which means they take this piece of the carotid artery here that's clogged up, they'll cut it out and replace it with a vein or some other kind of man-made stent that they use. Is it hypertension? Because a lot of people have hypertension, and hypertension is a persistently high blood pressure, often managed with lifestyle changes and antihypertensive medications. But the problem is, a lot of people don't want to take their medications because they don't like it, especially men. Men take beta blockers sometimes, and beta blockers cause erectile dysfunctions. And a guy would rather have a heart on than a fucking heart that works correctly. Heart failure is another one. The heart's inability to pump effectively causing symptoms like shortness of breath, edema. Management includes diuretics, ACE inhibitors, and lifestyle changes. So there's different types of heart failure. And then arrhythmias. Arrhythmias could be SVT, it could be VTAC, could be VFib, could be AFib. AFib is a common, that's where your atria are fibrillating, and so your heart's not pumping effectively. And if your atria don't pump effectively, your blood is not flowing, and the blood that's left over can create clots into the atria. And if you throw clots, then you're at risk for heart attacks, PEs, strokes. So we may have to monitor your heart rate when you're in AFib and control the rate. You have to be on anticoagulants to help keep yourself from having further issues. If you do have a clot or you don't get enough oxygen and nutrients to the tissues of the heart, you can have a myocardial infarction. A myocardial infarction is a blockage of blood flow to the heart muscle, presenting as severe chest pain and requiring immediate treatment and medications like PCI. PCI stands for percutaneous coronary intervention. That's just a fancy word for the fucking cath lab. All right. So we're going to talk about a case study here. You have a 50-year-old female. She presents to the ED with chest pain, shortness of breath. Her blood pressure is 150/90, and her heart rate is 110. Her respirations are 24, and her sats are 92% on room air. So if she's having chest pain, most people think she's going to have an MI, but how do you know that a patient has an MI? What's the first step that you have to take when you're assessing a patient and you're thinking that they have an MI? And the answer is a 12-lead EKG. Now, always follow your policy, always follow your scope of practice. But if you're ACLS certified, they have a myocardial infarction algorithm, which is kind of like your order set. And most hospitals will have a policy that just says follow ACLS protocol. And so if you're competent in ACLS and you understand the process, most of the time that you can just order the EKG. Most hospitals have a EKG protocol set into their order set. So you want to do an EKG because there's a thing called core measures. There's probably about 7 core measures in nursing. Chest pain and heart attack is one of those core measures. And there's 3 things that nurses must do if somebody's having chest pain to meet this core measure. And if we don't meet the core measure, evidence proves patients have a poor outcome, as well as the hospital won't get paid. And if the hospital won't get paid, they're going to kick your ass to the curb. So the initial management of chest pain is performing a 12 lead because we want to know where the heart attack is happening. Are they having an inferior wall? Are they having an anterior wall? Are they having a septal wall? The problem is nurses don't always know how to read an EKG, but it's not that difficult. But you only have 10 minutes from the time you suspect an MI or the patient starts complaining of chest pain to get an EKG. You have 10 minutes. Once you get the EKG, so we're going to look at this EKG here. Can't hardly see this, but if you do get an EKG, up here is lead 1, this is lead 2, lead 3. You have AVR, AVL, AVF, V1, V2, V3. You can't see it over here, it got cut off, V4, V5, V6. But when you read a 12 lead, this is the way you're reading it. Just remember that a 12 lead EKG is a mirror image of your patient. Your left is the patient's right. Your right is the patient's left. In the middle right here is the patient's septum. So over here, leads 2, 3, and AVF. These leads right here, 2, 3, and AVF, are on the left side of the screen or the left side of the 12 lead EKG. That is your patient's right ventricle or your inferior wall. And all you're doing is looking for this ST elevation. If you have ST elevation and leads 2, 3, and AVF, that is a sign of inferior wall MI. Now, the American Heart says you're not supposed to use nitro. However, if you listen to the AVS Avenger, he says there's a lot of research out there, and he's posted it on his TikTok and Instagram and all that. But there's a lot of research that shows this. It's not true that nitro is going to always hurt a right ventricle. It depends on how bad the heart attack is, where exactly it's happening. But you got to get blood flow to that tissue, because if you don't get blood flow to the tissue, the patient's going to die anyway, or the heart attack's going to get worse. If you did have ST elevation here in the middle of the EKG, that's an anterior or septal wall MI. And over here, you can't see it, but V5 and V6 are over here on the right-hand side of the 12 lead. V5 and V6 are underneath the left armpit, so you're looking at the patient through the left lateral. So we call that a lateral wall MI. So 12 leads aren't that hard. It's just we got to learn how to read them and just understand that they're a mirror image of our patient, all right? After we get to 12 lead, we want to make sure that we get cardiac biomarkers. We do troponins mostly. There's a troponin, and then there is a high sensitivity troponin. This is a protein that is by far the most commonly used biomarker. It has the highest known sensitivity. It enters into the bloodstream soon after the heart attack. It also stays in your bloodstream days after the biomarker is gone back to normal levels. So there's two forms of troponin that may be measured. There's your troponin T and a troponin 1. Troponin 1 is highly specific to the heart and stays higher and longer than the CKMB. Current guidelines for the American Heart says that this is the best biomarker for finding a heart attack. And the AHA also says that you should limit the use of these other biomarkers that include the CK, the CKMB, and the myoglobin. Creatinine kinase, the CK, this enzyme is also measured several times over a 24-hour period. It will often at least double if you've had a heart attack. But because levels of CK can go up and many other reasons, such as kidney issues and things like that, it's not very specific. And in the CKMB, it's like a subtype of the CK. It's more sensitive for finding heart damage from the heart attack. The CKMB rises 4 to 6 hours after the heart attack, but is generally back to normal in a day or two. Because of this, it's not that helpful when a healthcare provider is trying to figure out if it's a recent heart attack or old heart attack. And then the myoglobin is a small protein that stores oxygen. It's measured occasionally. Myoglobin is sometimes measured in addition to troponin to help diagnose a heart attack. We also use myoglobin in rhabdomyolysis because when you get crush injuries, you're crushing red blood cells, you're crushing muscle and protein. And when it gets into the bloodstream, it can cause problems with the patient's kidneys and release a bunch of electrolytes like sodium, potassium, things like that. So if you do have a patient with a MI, you want to make sure after the physician diagnoses them with the STEMI off the 12 lead, you want to administer chewable aspirin, not enteric-coated, 162 milligrams to 325 milligrams, and you only have 30 minutes to do it. Again, that time frame is part of the protocol, the core measures for heart attacks and MIs. Then you want to prepare for PCI or percutaneous coronary intervention, aka cath lab. This procedure is used to open the blocked artery. They go in, they put a stent in, they remove whatever they need to, the clot or the plaque, and they leave a stent in so it doesn't close back. So the American Heart says first medical contact to balloon inflation time is 90 minutes. But here in the valley where we live, we are down to about an hour. Some people even sooner than that. Some places in the valley don't even have a cath lab, so they have to transfer the patients or they have to do what's called reperfusion therapy. So just like with strokes, you give RTPA or tenecteplase to break open the clot for the stroke. If you're at a place where they can't transfer them and the patient's so unstable, they may give a medication that's a clot buster or a fibrinolytic, and that's just called reperfusion therapy. But again, getting the patient to the cath lab, this is your third core measure time. So EKG is 10 minutes, aspirin is 30 minutes, PCI or cath lab is 90 minutes. All right. So when you are trying to take care of a patient that has cardiac issues and you're doing your head to toe assessment, you want to come in, you want to check their pulses, you want to check their skin, you want to listen to the heart sounds, you want to listen to their lung sounds, look at their skin. Is it cool, pale, moist? Is it warm and dry? Is it mottled? Check the pulses, check their JVDs. These are things that as a nurse, you want to make sure you do so that way you are being more effective with your patient. So what I did was I created again for the third time in this series, I created a comprehensive guide, and you can go to our website, transformationnurseacademy.com, go to the store, and then you can download the ebook for free. Right now, I'm not charging anybody anything, so that way it's just a tool that you can use. Goes over, and I'll tell you what the table of contents are here. Let me look and I'll tell you. I know I should have it memorized, but I don't. I suffer from CRS. So it covers anatomy and physiology of the cardiovascular system, the cardiovascular assessment in emergency or med-surg setting, common cardiovascular medications, common cardiovascular disease processes. We cover the heart anatomy, we cover the valves, the conduction system, we cover the blood flow, we cover history taking, physical examination, additional assessments. I go into greater detail. So like history taking, we talked about some of this chest pain, shortness of breath, palpitations, dizziness, peripheral edema that may be associated with it, family history. And then we go on to talk about physical examination, talking about skin color, edema, JVD. I go into depth more about that. And then I cover medications. So the big medications is aspirin. Those are the medications that we're using. There's different names. There's Bayer, there's Ecotrin, and then we talk about the mechanism of action. Aspirin is an antiplatelet. Aspirin irreversibly inhibits the cyclooxygenase, or COX-1. I said COX enzyme in platelets. This inhibition prevents the formation of the thromboxane A2, a potent vasoconstrictor and promoter of platelet aggregation. By reducing the A2 production, aspirin decreases platelet aggregation and prevents clot formation, thus reducing the risk of a heart attack and stroke. So when you learn in school from those old ass teachers that tell you that aspirin is a blood thinner or heparin is a blood thinner, it's not a fucking blood thinner. It's better if you say a blood slicker than a blood thinner, but it doesn't make your damn blood thick. Some of the side effects of aspirin: gastrointestinal bleeding, dyspepsia, nausea, allergic reaction, tinnitus at high doses. So the common dose that we're going to give is 81 to 325. Contraindications: active bleeding, peptic ulcer disease, hypersensitivity to NSAIDs, asthma, and renal impairment. So I go over a few medications that are important to the cardiovascular system, the dosage, and then I go over like AFib. I go over hypertension, myocardial infarction. So it's a great comprehensive guide. And so you want to make sure that you have a great head to toe assessment. So we started out with adult triage, we did pediatric triage, we did neuro triage. Today we're doing cardiovascular triage. All right, so again, it's a little short episode because we're just doing segments. We're going head to toe. Some might be longer, some might be shorter, but I appreciate you guys. I hope you learned a lot. Again, download the ebook. Visit us on TikTok, Instagram, Facebook, all that shit. So that way, you get more educated and you can become a better nurse. If you have any questions, you can follow us. Like I said, Facebook, Instagram, TikTok, YouTube. You can email us. You can contact us on the website. All right, you guys. I hope you fucking have fun. I hope you learned a lot. Later, bitches.
Don't miss out. Engage with us weekly. Share your thoughts, and let's transform the nursing landscape together.